As we wait, I would like to introduce myself. As some of you may know, my name is Madison Burnett, and I'm a BCBA, and I lead our professional development program, and I'll be supporting throughout the webinar today. In addition to that role, I work alongside other BCBAs on our clinician-led recruitment team, and I support in the effort of recruiting quality professionals to join our team, like all of you. Next, for some housekeeping information. For those seeking seat use for this presentation, you will need to attend it in its entirety with a minimum of 100 cumulative minutes in order to receive a link to the post-webinar quiz and survey following the presentation. We'll be verifying your attendance by reviewing the time attended logged in Zoom, and we'll send out an email containing the link for the post-webinar survey. We will be leaving the chat open, but please post any questions you have in the Q&A so we can make sure that they are seen. All right, and now I would love to introduce our presenters. Dr. Amanda Kelly is widely known as Behavior Babe and is a leading voice in ABA with over 2 decades of experience dedicated to advancing ethical practices and expanding access to services. In 2024, Dr. Kelly stepped into the role of Director of Adult Programs at the Unum Center for Neurodevelopment, where she continues her commitment to creating meaningful opportunities, particularly for profoundly impacted adults. Renowned for her impactful leadership, relentless advocacy, and dedication to ethical excellence, Dr. Kelly's work inspires and uplifts the global ABA community. Dr. Amy Foxman is the founder and president of Ability ABA and is a BCBA and certified special and general education teacher. Throughout her career, Amy has worked extensively with individuals with autism and other disabilities, from early childhood to adult, in providing both direct and clinical consultant services in a variety of different settings. Amy enjoys using a compassion and research-based approach to ABA as she partners with families and professionals to individualize programs for each individual's success. And now, without further ado, I will hand it over to our presenters.
Thank you, Lauren. I'm just going to say hello for a few moments while Amy goes ahead and navigates to get her screen share up. And Amy, you're faster than I am in even getting my words out this morning. Thank you again for having us here today with the Manhattan Psychology Group. Amy, I'll turn it over to you.
Yes, thank you so much for having us. We're very excited to be here. Amanda and I are kind of a duo with this, so you'll hear us talking back and forth, and I just want to preface it that we love like comments and questions throughout. So, shout it out in the chat box, or if you have a mic, interrupt us. But participation is definitely more than welcome. We wanted to start with our story and how we ended up working together. So I think, Amanda, you're the best to kick that off.
All right, thank you. Gosh, so today's talk is really about prevention and about action. And so what we want to do is Amy and I are very interested in providing tangible resources and immediate items in which people can engage in new behavior change, hopefully right away, that will improve your outcomes for your clients or will improve the way in which you're approaching this particular topic with your clients, with the families that you support and serve. For me, it became something that wasn't necessarily at the front of my mind in the years that I've been working in the field. And it wasn't until, really having the opportunity to collaborate and to get to know so many different people. In March of 2020, and many of you may have blocked that out, but I'll remind us just briefly that it was the COVID-19 pandemic. And in March of 2020, I was slated to speak at Calaba with a dear friend of mine who's pictured here on the screen, Feda Amalidi. Feda is an autism mom and an advocate, a powerful advocate at that. And we're both also renowned procrastinators. And so we had not yet prepared our PowerPoint slide for our invited keynote, or not keynote, but invited dissemination talk and advocacy talk. And we were going to work on it, the night that we got there, as one does. And so we walked into the building, we got ready to go into the conference. And as we're walking right into the conference hall or into the hotel, we got word that the conference had been canceled. And talk about a reinforcer for procrastination, because we ended up not having to present that talk. And then actually I ended up staying in California for the duration of my trip. And Feda allowed me and invited me to join her in her home with her son, who's also pictured here, Muhammad, or Moo, as he's lovingly referred to. And I got to spend 10 days living in their home. And I will tell you, spending time with your friends, with who have family members who are profoundly impaired, is probably the best education I've ever received, is the experience I get from being immersed in their lives, even just for a few moments or a few days. So I got to spend those 10 days with them, and I'm super grateful that I did. And unfortunately, that would be the last time when I left their house on Friday the 13th of 2020, March. That would be the last time that I would physically see them in person again before their deaths. And September 26th, specifically of 2020, we received news that Feda and Muhammad had perished in a house fire. She just seems larger and is larger than life, and it would take nothing short than flames and smoke engulfing her in her home to lead us there. And so to me, I just thought, how could this be the end of their story? And I'm really grateful that it's not. And the spring of 2022, actually, I was given the opportunity from Texas ABA to come and present and to come and talk about Feda's advocacy, because she's a powerful advocate, and also her legacy. We did mention and talk about the tragedy, and it was a 3-hour talk. So it was something that I could only do with the help of friends and colleagues who shared videos. But that is really where Amy and I first met, and where our stories start to intersect, or at least where we realized that they were intersecting, because during that time, Amy, you were working on your dissertation.
Yeah, so when the tragic accident happened with Feda and Moo, and I remember that time as well in September of 2020, we were all at our computers, like a lot was still shut down. So I was in front of my computer. I was just starting to dive into my dissertation on fire safety for children with autism. And so the news came out that they had tragically died in a fire. And something that Amanda didn't mention that is heartbreaking are kind of the details of it, which is that Moo wouldn't go down the stairs to exit the house. And it was the middle of the night, and all the sensorial aspects of the fire were happening, and Feda was begging him to come down the stairs. And so both of them were found at the top of the stairs. And so it was extraordinarily tragic, and it really reinforced for me in that moment that my dissertation, which was teaching children how to safely exit during a fire when a fire alarm goes off or they see fire, was this critical skill that really needed to be worked on. And so then fast forward to when Amanda was presenting at TechSaba. And I thought, wow, this is great. Someone else is thinking about this and getting the word out. And I'm ready to have something tangible to bring back to the clinicians that I work with in my own practice. Like there wasn't anything out at the time of like, this is one that you need to work on fire safety, and two, this is how you do it. Like there were no resources. And so I attended Amanda's presentation, and it was beautifully done, and she really honored both of them. And there was one woman who had a child with profound autism, and that she demonstrated some really neat things, which we can talk about later. But there unfortunately wasn't, like, I was ready for some kind of handout, like this is what you need to do, and there wasn't that because it didn't exist. And so when I finished my dissertation, I reached out to Amanda, just cold emailed her, and I'm a huge introvert. So it took a lot. And I said, listen, I don't know you. I watched your presentation. I'm so sorry about what happened to your friends. It is horrible. This is my specialty, fire safety. And I really think that we can do something beautiful together. And so we did. And as Amanda kind of at the beginning of this talked about, our goal was to have some kind of like tangible resources for clinicians and things that can be used in practice that can truly help save lives if we're at least getting the conversation started around not only fire safety, but all sorts of safety skills. Because it's not, I mean, it touches it a little bit in some assessments, but there's nothing really that comprehensive that addresses safety skills. So that's how we came together, and that's how this was born. And we're really grateful that you're here to talk about it with us. This is an ethics presentation, so I'll have a few points of our talk that go through some of the ethical code. 3.01 responsibility to clients. This is one that we all know like the back of our hand, but the ability to act in the best interest of our clients and taking appropriate steps to maximize their benefits and their rights. And we think safety is a right, and safety is so critical to address. And so we really believe that working on safety skills is a huge responsibility on our part to the clients and stakeholders and families that we work with. Our biggest message here is like save lives, and let's try to prevent an accident like this from happening to anyone else. Amanda, you want to go over these?
Absolutely, not a problem. So our learning objectives are just a launching point. We really hope that the conversations that we have today, you'll walk away with even more information. But at a minimum, we would love for you to be able to reference at least one of the safety statistics that we are going to be speaking to, specific to children and adults with autism or autistic individuals. We also want you to be able to locate at least one assessment tool. Hint, 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 we're going to provide that tool to you or that resource today. At least one that will help identify some safety concerns for the individuals that we're supporting, especially when we're responsible for conducting assessments. And then describe a procedure for how you might teach this critical safety skill or a specific critical safety skill for an autistic individual or anybody that you may be supporting or serving. And so those are the things that we hope at a bare minimum you'll be stepping away with today after our conversations. And we're going to begin by sharing with you some of those staggering statistics. We think that this information is very helpful to talk about the context of why this is important. We know that individuals, especially individuals who are autistic, have a tendency to gravitate towards water, have a tendency to drown or to come to harm, especially because of lack of awareness or potentially lack of understanding of the dangers associated with those activities or those environments. And so drowning in particular is one that I was aware of, but I was not aware of the level of just how staggering the statistic is. And that is that individuals with ASD are 160 times more likely to die from drowning compared to the general pediatric population. And that's a relatively recent statistic, or that information comes from something that's relatively recent in the research. And we don't exactly know why that is, but we do know that that is a commonality. And so as we're thinking about these things, what are we doing as clinicians to be identifying these concerns and teaching the skills that are needed to increase the likelihood that the individuals we support will be able to safely navigate those environments? There's a couple of different sources of information on this, and so we want to just, again, preface this within the context of the Columbia Mailman School of Public Health and the resource reference that we have here from 2017. But that resource talks to us about the average age of death for autistic individuals. Now, I don't suppose that we have any information that talks about a lower age of a shorter age span or lifespan for individuals that has anything to do with just your average typical internal health. That's not something that we're seeing, but we're seeing a real big impact because of the dangers of the environment, the lack of awareness, and again, this gravitation. So what we found was information suggested that the average age of death for individuals with autism was 36 years younger, or basically half the age of individuals in the general population. Of the deaths that were reported here, 28% were attributed to injury, most often due to suffocation, which was followed by asphyxiation and drowning. And a lot of times those are different technical pieces that could be associated with drowning itself. These three causes accounted for nearly 80% of the total injury mortality, specifically for children. And the information noted that 40% occurred in home or in residential institutions. So when we think about Feta and we think about Mu, again, somebody who was so involved, both of them, such strong, powerful advocates, had actually been 1/3 of that tripod that really helped establish access to autism insurance in California. Um, Powerful, immersed, educated, strong-willed, and yet this tragedy happened in their own home. And so it's not about not being educated or connected or having information. It's about there being so many things to prioritize that I think we often look at what's immediately right in front of us that we need to teach right now, and we don't think about the things that are a little bit more abstract and potentially more horrific or traumatic in that way.
And if we just talk about drowning, I mean, programs aren't for the most part teaching swimming and safety skills with water. And if we look at, Amanda and I have spoken to so many different groups and schools across the country, and they don't have swim lessons as part of their programs. And the majority of ABA programs don't teach swimming and water safety. And swim lessons are very hard for the majority of the population to access, whether it's limitations in scheduling and being able to do it, and providers that will work with a child with autism, and financially. So when I was in Seattle, I used to teach, and there were huge bodies of water in Seattle, and it was amazing. The school district actually provided swimming lessons once a week for our class with severe autism. But that's the anomaly. That is not happening across the country. And here in Texas, we have pools everywhere. I mean, literally most backyards in certain areas have swimming pools. And nothing is written into curriculum or ABA programs on safety around these bodies of water. So extremely concerning and something that needs to be done as we move forward. Elopement prevalence, it goes hand in hand with the prevalence of drowning, because if a child elopes, then they're very likely to go to a body of water. So these are some statistics that we have. 49% of children with autism attempted to elope at least one time after age 4. And of those that attempted, more than half went missing long enough to cause concern. And from the younger ages 4 to 7, 46% of children with autism elope, which is 4 times the rate of their unaffected siblings. And you still have 27% of affected children ages 8 to 11 compared to 1% of unaffected siblings. So these statistics are not great. And as clinicians, I know that we see elopement in our clinics, but how do we also work with families that if there's a child or an adult who may elope from their home, what are we doing to help families navigate that and hopefully prevent it?
And I think, Amy, another point that we can make here too is that families are often very much aware if their children are especially frequent elopers. And when we say children, we could mean adult children or young children here. Just know we're speaking about that for families. And in some cases, families have told us that they've had to rearrange the environment in their house, have their child live up or bedroom be upstairs versus downstairs, which might be very helpful in preventing elopement, but might be very challenging when trying to evacuate the house. And so there are lots of reasons why they may need to prioritize. And as we're having these conversations, like Amy mentioned, with different organizations and individuals around the country, we're realizing just what those needs are and how complex they are, and how we need to do our best to support families in kind of considering all of those factors and variables. So although Amy and I talked about getting interested in our first sort of area of need that drew us together was fire and fire safety, elopement and water safety also became of particular interest. And just some additional statistics here is that, 74% of affected children who elope from home also were, they were eloping from their own home or someone else's home. So again, these are things that are happening oftentimes, maybe not even in our presence. So as we're thinking about how to support and teach the individuals that we are supporting these skills and their families these skills, realize that they're going to need to demonstrate these skills in environments that are a bit more chaotic, probably a little less structured, or have different resources and different staffing ratios. And at home, they don't really have staff, right? They have, their family and their family dynamic. Close calls with traffic injury were reported for 65% of the missing children. So if water's not a danger, of course, running into traffic definitely could be a danger. And then what we noticed, or what the information shared with us here, is that many families were reporting this is happening multiple times per week or even several times per day. And so you think about the constant level of fatigue that they might experience from having to be so alert all the time. And what we know is it just takes a second. It is not necessarily a reflection of not paying attention or bad or poor parenting or anything like that. It just takes a second. And in the blink of an eye, we could have a situation where somebody is now wandering and potentially wandering towards water. Close calls with drowning were reported for nearly a quarter, or 24% of the missing children.
So, a kind of important aspect of this is that in the Lancet Journal published that while people with autism do die prematurely, that the majority could be reduced by better support, inclusion, and changes that facilitate access to services. So this idea of that these are in some ways preventable, that if we're able to improve our support and address some of these challenges that contribute, that we can reduce that number of premature deaths. And as behavior analysts, educators, people with touch points with individuals with autism and other disabilities, it really becomes part of our obligation to make that change happen, is what Amanda and I believe. The safety skills in autism, in particular, for an individual with autism, a lot of the deficits around autism influence their ability to respond successfully to any safety threats. So kind of one aspect is the ability to successfully learn. This idea, as children, we have fire drills in school. And while a child who doesn't have autism or is typically developing may be able to successfully make the connection that when I hear the fire alarm in school and we have to exit the building, I'll do the same at home, that I need to stop what I'm doing and exit. That correlation isn't necessarily happening. It may not be automatic, that there takes a lot of intentional teaching in order for a child to learn what a fire alarm means in different places. And that's just one example. The persistent challenges with social communication, social interaction can also impede one's ability to respond to various safety threats. So if I were to sit here or stand here and yell to a room full of people, there's a fire, and you immediately know by what I'm saying and the tone of my voice, like, I got to get out. And I see people moving. And so people are going to go in that direction. But again, this isn't an automatic. That's some of the deficits related to autism, that the tone of voice, the urgency, the people leaving, that it may not be an automatic response for an individual to follow that and to stop what they're doing. And that goes along with deficits in nonverbal communication too. Restricted and repetitive patterns of behavior or interests or activities. If an individual with autism is doing their favorite puzzle or watching their favorite TV show, are they still going to be able to stop what they're doing when the fire alarm goes off and immediately stop that activity? Sometimes that can be very difficult. And then different sensory input that's happening when there may be a safety threat, whether it's loud noises, screaming, sirens, heat, kind of any sort of aspect can also affect their ability to respond safely. All these things contribute to why this is so critical for us to be addressing this in our work. So we know that individuals with autism may be more vulnerable during different emergency situations because of all these different areas that impact them. And, a lot of times, whether it's in a school, in a home, in a clinic, we can think about having personalized emergency plans for a student with a disability or a student with autism. And it may be specific instructions of what people around them are doing to help support them in this safety threat. So even if the child I'm working with doesn't have all the skills necessary to exit safely in a fire, that we have a plan in place for if there were a fire alarm to go off or a fire in the home or in their classroom, this is what's going to happen, and this is how they're going to be most supported and successful in this potential safety situation. And this can translate to community outings if you're in an ABA program or a school on a field trip. And so, or what parents are doing when they're out in public, so it has a lot of different ways that it can be generalized. And one question is why we don't prioritize these skills if they're so important and they're so critical. And, it boils down to, a few things, but one is limited resources and time. And, especially if I have a parent who is, has an early childhood kid and their child is struggling with just basic communication, saying if they're hungry or thirsty or need to go to the bathroom or tired or they want something, those are such critical challenges for the moment. And so we say, let's work on these. And, the probability of a fire happening in a home or at our clinic is very low. And so those are sometimes what those immediate and impactful goals are, what end up taking priority in our programming. Um, we're also, very highly individualized in our treatment programs. And so I've brought up safety skills and intakes with parents, and a lot of times they say, no, 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 I don't care if they safely cross the street. They're always with me. They're always with an adult. My priority is that my child can sit at mealtime for 20 minutes at dinner every night because it's really tough for us. And this is what we want to be focusing on. And so it really depends family to family and what's meaningful for that family. But these are all discussions, that that we're having, but also an answer to why we're not prioritizing some of them.
Yeah, and to further elaborate on what Amy's speaking about here, this phenomenon, we really feel like it's best captured in what's known as the picnic analysis. And the picnic analysis was something that was developed by Dr. Aubrey Daniels and Dr. John Bailey. And what they talk about here is exactly that phenomena Amy was describing, which is whatever is more likely to occur, whatever is more immediate and certain in an environment, whether it is positive or negative, we are more likely to arrange our behavior around that. And so let me give you a couple of examples once I explain what PICNIC stands for. So PICNIC stands for positive, immediate, and certain, or negative, immediate, and certain. And you can see we have an infographic on the right-hand side of the screen here. And what it means is things that are positive or negative, if they are immediate and certain in your environment, then you're more likely again to arrange your behavior around those things. So a family is more likely to want to have their child to communicate, to be able to develop independence in the bathroom, to be able to eat new foods or whatever they may be working on, especially if they're early learners. And as Amy said, it may not be a priority for them to focus on something else, perhaps like crossing the street, brushing their teeth, etc. They just might have a different prioritization. And maybe they would pick brushing your teeth. It's all going to depend on that individual. But if things are more likely to occur, again, we're going to focus on them. But if they're further away, so if somebody says to you, if you smoke cigarettes, you're going to die of emphysema when you're 75 years old, that is negative, delayed, and uncertain, meaning like it might happen, it might not, but we don't really see the connection between our behavior today and that outcome because it's so far away. So I'm going to do what I want to do. However, if somebody said, hey, if you engage in that smoking behavior, you cannot come into this conference hall, you have to wash your hands, you have to change your clothes, you have to shower, you have to blow out your hair, you might be like, you know what, forget it. I'm not going to do that today. It's negative, but that consequence is immediate and certain. When we talk about fire safety or we talk about elopement and wandering, it's a negative outcome and it's delayed and it's uncertain, I guess, depending on the individual, what the certainty is that they might engage in that behavior. And so we are more likely to select what's positive, immediately applicable to our lives, what's going to happen most frequently, what are we going to have the most opportunities for teaching and therefore shaping and reinforcing. And other times why we think that families don't, necessarily prioritize this, or we may not prioritize this with families is maybe it's out of our skill set. Maybe we feel uncomfortable teaching it. Maybe we also think there are so many things in the immediate environments that we're like, we must tackle these things that we don't know when to give how much attention to what. And so we are here today to continue those conversations with you, because sometimes we realize when we're having these conversations with members of our community, it simply didn't occur to us. We were prioritizing things and we were not thinking about things that were maybe a little bit more delayed or uncertain for an individual. So for example, I'll go back and use Muhammad, talk a little bit about him, because I see him as a dear friend of mine as well. Things he was working on, I mean, he was working on communication, he was working on ordering things, he was working on, being able to grocery shop and follow lists. He was working on many very valuable things. At the same time, one of the things that they had wanted to work on was actually his bending or crawling. And I remember the health plan said, why? Like, why would he need to do that? And it was really because they want him to be able to put his shoes on, be able to bend down, pick things up off the floor. It's very necessary to have that skill to be able to bend down and touch your toes, right? Not necessarily that you even needed to crawl, but to be able to do those things. I had the ability to do those things. We weren't thinking fire. We were thinking more of the immediate things like bend down, pick up your shoes, pick up something you dropped off the floor. But when we think about something that's a bit more delayed, we could actually focus on a skill that could have an immediate relevance and a more long-term benefit. So there might be some ways in which we could look at doing that for the families or the individuals we support.
What we're going to talk about today is a qualitative assessment, and it's really full of open-ended questions and a way to explore different thoughts in whoever you're interviewing or you're thinking about. And it also lets you dive into some sometimes more sensitive issues, and safety skills are sensitive. I mean, if I'm talking to a parent, does your pool have gates over it? Can your child unlock your doors? Is it a concern if they do unlock your doors that they'll be leaving the house? I mean, these are very sensitive because a parent is, before their eyes sometimes is flashing, my gosh, something serious could happen to my child and my loved one because they don't have these skills in their repertoire and their ability to distinguish between safe and unsafe. And so they're hard conversations. They're typically, not appropriate for yes, no. It's really about exploring what's going on with that person. And from there, we can get to places where we can prioritize safety skills or think about, what may be more critical to address, especially if we're limited in our time or our resources to do so. And back to the code of ethics, this really brings home 2.09, which is involving client stakeholders. Behavior analysts make appropriate efforts to involve clients and relevant stakeholders throughout the service relationship, including selecting goals, selecting and designing assessments and behavior change interventions, and conducting continual progress monitoring. And so while I may think that teaching your child to safely cross the street should be a number one priority, it's not necessarily about what I think, that it's really about what the stakeholders in that person's life think and what's going to be most meaningful for them and the client that we're working with.
Amy, I recently attended a presentation by Dr. Malik Pritchett. And one of the things that she talked about was showing a grassy field, a very open grassy field, like in Texas, for example. And I know it's, you live in Texas. And she said, would we prioritize crossing the street for an individual here who's living on like 100 acres of land? And it's like, you definitely might, but she was giving us examples of what is another more relevant safety factor. And it might be how to identify venomous versus non-venomous snakes, which may be something they're more likely to encounter while they're out there roaming around and playing. And so I loved that really clear, tangible, concrete example and the visual she had in her presentation as well, about involving clients and stakeholders. And by doing so, you're going to realize like, oh yeah, it's not that safety is not a priority. It was safety in the context of that environment. And so I just thought that we wouldn't have even come to had she not, or had they not involved the clients and the stakeholders.
Right. And without kind of the open-ended question too. I mean, if we're just asking those yes, no questions, then we never will get to a concern about, identifying venomous snakes and how to respond. I mean, that's on no assessment that I have ever done. So I think that really brings it back home of why the conversations are so important. I once had a family who they went bike riding every weekend, and it was, a critical part of their family routine. And the child wouldn't get strapped into the attachment that they rode on the bike with. And so the ability to wear a seatbelt and the bike attachment, was really critical, and potentially life-saving for that child and family. But again, we wouldn't have gotten there with just yes, no questions. We would have talked about being in a car seat and safety around that. So current assessments, I mean, we found that there weren't really assessments, which is what we talked about at the beginning and what brought Amanda and I together, is that nothing really existed that was like written out. And there are people that have certainly addressed safety in different areas, but that there just aren't a lot of resources out there for comprehensive safety assessments. And so what we did is we worked together to create one. And we call it the safety assessment for everyone today. And we say today because, um, we don't want it to be too late, that we can always start now. And the idea of we can start now and we can start anytime. And today's the day to be starting this. And so it is full of open-ended questions in different safety domains. And it is accessible and free. You can go to my website or Amanda's, and our information is at the end of the presentation, but it's available for anyone to use. And the purpose was to offer a framework to just start identifying different risks and safety concerns that are relevant to the well-being of people that we work with. And yeah, there's no time like the present, as Amanda says. But the information gathered through this is just a foundation for understanding what different factors, environmental, behavioral, situational, that may pose hazards to people that we work with, and it gets the discussion started. A disclaimer that this is just a preliminary assessment tool. It's helpful in hopefully identifying potential safety risks and having more discussions about them and taking action, because it doesn't just stop there, right? So, we have to do something about it. But it should really be done in conjunction with a broader evaluation for the person. And we recommend working with professionals just like you, or other professionals, to come up with an individualized approach to safety planning. And this assessment can help be a guide in doing that. So these are a few areas of consideration that the assessment addresses. As we've talked about: fire safety, environmental safety, choking and breathing concerns, water safety. We have a section on school safety, social media. Again, different aspects. Safety is very encompassing. And so there's a lot that we don't think about, and hopefully this lets people start thinking about it. It's a non-exhaustive list, and we also say, excuse me, using our contact information in the back, like if there are other things that you think should be in here, we love it. This is a work in progress. We're continually revising it to be more helpful for practitioners and families. So what we wanted to do right now is kind of work together to talk about some of these areas. And so we have school safety as a topic, but this really doesn't just apply to schools. It applies to clinics and community spaces. But these are some of the questions that we have in our assessment. And we wanted to kind of hear from y'all about things that you're working on in clinic spaces or schools or communities, and what concerns you have in terms of safety. And we've found that this kind of sharing and working together to talk about this, that it can, get a lot of ideas and can be helpful. So we wanted to open it up to the chat and to your audio as well, and just kind of hear from you about some meaningful areas of school safety, or again, clinic, or community spaces that you've worked on, or challenges that you've seen.
While you're taking a moment to review maybe some of the questions that we have as prompts, or you're thinking about if there's a question you have for us or an area that you'd like to share, I'm happy to kind of talk us through a little bit of some of the questions that are here and some of the discussions that Amy and I have been having with people as we're having these presentations and these conversations. For example, one of the topics that comes up so many times is people talking about substitute teacher preparation. So maybe this is something that's in place. Again, if we're talking about in schools, then you would need to know, like, what does somebody do if this isn't normally the classroom I support? But if we're talking about in clinics, what do I do if this is not normally the part of the building I'm working in? Like, is that something that's different or unique? Is it something that you're familiar with? If we're talking about the physical environment, but we're thinking about somebody who may engage in elopement behaviors, are we thinking about how many offices they might need to go to, or how many doorways they might need to pass through before they can get outside? These are not always things that we can shift or change, but they're things that we can start asking and becoming aware of. Other things that I see when I think about safety skills or things that people teach, we often teach directions such as wait or stop, but we're doing them under very controlled, strict sort of teaching environments or conditions, a bit sanitized, which is fabulous for a teaching environment. That's absolutely fine to emphasize the salient feature of what we're trying to teach. But often, are we doing that from needing to call at somebody, or are we doing that when does somebody need to immediately stop what they're doing and transition into following a new instruction, or exiting the building, or turning off the lights, whatever the threat might be? That's something that a lot of individuals would say, no, we don't work on that, or we haven't worked on that, or we hadn't thought to work on that. And so, as we've mentioned, that we've originally developed this as an assessment tool, particularly for caregivers, I think it's really important to emphasize stakeholders and caregivers can also extend to meaning teachers or other support professionals. It doesn't always mean family members.
I know when I was in a clinic-based setting that, yes, we had fire drills and yes, we had tornado drills, but it was more of getting clients used to having those procedures in place, not focusing on, hey, this should be generalized to home. So definitely a different perspective and very important.
Yeah, thanks for bringing that up, Madison. A big thing that we see, and even I used to be a teacher, so we would do this, is that when there was a fire drill, that we all knew that it was going to be happening at 9:30 in the morning, and our principal and the school would send out an email just to me, who taught in the behavior program with kids with autism, and she'd say, "Just want to give you a heads up, like the fire drill is happening at 9:30," and so then we would get our go bags ready. We'd get kids that needed headphones. We'd have them on at 9:25. We had extra staff down there with us. And the reality is that if there's a real fire alarm or fire happening, that none of that is going to happen. And so, it's really a disservice to those kids and the staff to be practicing it in that way. And if we're in the clinic too, that we shouldn't, this idea of just kind of like, we would usher kids out, like, let's just get them out the door. And we were so happy, like we did it. We got the kids out the door with the fire alarm sounding. But it should be different. It should be, not only, how do we get everyone to safety and do it when we're caught off guard? But what skills does each child need, or adult if we're in a setting with adults, to be successful when a fire alarm happens and it's out of routine? And that's something that a lot of places aren't doing.
And Amy, I really appreciate you mentioning that because I think so many of us can connect to that being our experience, or at least we've experienced that probably at some part of our career and practice. I think the other piece that I've realized when we've had events happen that were not drills is that the staff are not prepared. Like we're so used to being told what was coming that when something we weren't aware of it. For example, a bomb threat, and we needed to lock down. Then there was a moment where we needed to evacuate, and because we weren't told about it, we knew it wasn't a drill, and I think that really increased the anxiety and confusion for the staff and for the teachers. And then what I experienced because I was the counselor and working with administration, what we realized was we were setting people up to be almost in like a hyper state of arousal because they had not prepared how to stay calm in the event of being caught off guard. And so it was a disservice to the people who are there to support the individuals, children or adults. If we aren't able to maintain calm, if we're not able to communicate calm, it is only going to increase the chaos in the moment, which is going to increase the likelihood that danger or harm is going to happen. And we want to, of course, minimize, prevent, and decrease. So even from a tangible action, something to talk to about with your team members and your organization or any organization or group that you're a part of is trying to make sure that people are prepared for drills. We don't want people to also be in contrived situations where they're feeling panicked, but prepared to be caught off guard, if you will, so that we can almost have it routine or practice to be in that place of calm or homeostasis in a potential real crisis.
And thanks for bringing it up, Amanda. It is really important that we're preparing everyone that we work with for that, the professionals who are supporting. Yeah, I want to also bring it back to substitute teachers because, I'm in an ABA clinic and there's a lot of substitute therapists. And that's one thing too to prepare for is just that when you have a substitute therapist, are they also aware of the student's safety plan and safety concerns and what needs to be done in a lot of different, aspects. So I'm really glad that you brought that up, Amanda. Are there anyone else that's um experienced different aspects of safety around schools or clinics or in the community? I'll say a couple other things then that we've gotten as we've talked to other groups that I think are interesting and good things to think about are kind of this idea of a go bag, that if there is an emergency, that you have a bag that's just set for emergencies, and it can have low tech AAC for students. It can have contact information for critical people and their lives or your patients' lives. It can have, things like fidgets or preferred items that if you're stuck in a lockdown or a tornado alarm is going off, that you're really prepared and that you can help keep calm, the individuals that you're working with. So we're in Texas here. We have tornadoes. There's actually a chance that one may be passing by any moment. Hopefully not. But we have go bags. So, even my own young daughter, in our safe area in my home where we go in the event of the tornado, I have a bag of her favorite things there because it can be really, really scary during a true tornado alarm going off. And so I want things that are going to help comfort her and keep her distracted and keep her safe. And that goes with kind of everyone that I work with. That I want to make sure that I have those items. And so that's something that a lot of times, if you're in a school, sometimes the teachers will carry it with them. If the class is going to, let's say, PE or the class is going outside, they always also have that bag with them. So they're very prepared that if something were to happen in a different location within the building or environment, that they have those items. Okay. The next one, the next category we have is wandering in public spaces. Again, these are just some of the questions that are within the assessment. It's actually think a longer list than this, but some things to think about around wandering. Is the child or adult able to identify, their name, give their phone number, or give a phone number of someone that can be contacted in the event that that they're not with them, or do they have some sort of ID or alternative identification? What about medications? Is the individual able to vocalize what kind of medications that they may need? And do they know that they need to have it on them? So it really depends and is individualized to each person. And a lot of questions about just if this is a risk for the person, what would happen if they're separated from caregivers? Would they wander off? Would they, go with an unknown adult? I worked with a child that if there was a car door open, he was really interested in certain places and cars. And so if he saw a car door open, he would like jump into the car of a complete stranger, which in Texas is very dangerous on many levels. A lot of people carry guns here. And so as he gets older, it's not this cute little kid going into a car. But it's a big risk. Are there any kind of other thoughts that y'all have experienced in terms of wandering in public spaces?
So Amanda put in the chat of different things that might be important to have. What would you recommend for either a school or a community-based setting for contact info for individuals who might also wander? Do you attach any sort of identifying pieces to their backpack or their clothes so they can get back to the group that they are assigned to?
So I would say yes. I mean, when I was a teacher, we did, if we ever went on field trips, we would attach onto each person's shirt identifying information and contact. But Amanda and I really recommend that if there's someone that may be prone to wandering, that they do have that identification on them at all times, whether or not there's an unusual activity going on.
Yes, I agree with that. And there's different devices and things that people can access and use, and sometimes they are really helpful, and sometimes they're prohibitive for cost aspects. If that's the case, we encourage families to reach out to those companies because a lot of times they will offer discounts or the devices themselves, or are able to get scholarships or funding. Because what Amy and I've realized is that when there are resources out there, a barrier can be the access, right? Even though they may exist, who's funding them, or how are people able to access them from like a transportation issue. So there's a lot of variables and things here. I'm noticing in the chat too, Claire, thanks for sharing this piece, giving an example of having students being able to tell 3 things around them, like if they were separated. So using some of that descriptive I guess, language. We had a similar thought to number 10, talking about, again, using devices, maybe something as common as a smartphone. And could we teach individuals, or if we were to ask families, do they know how to use FaceTime? Do they know how to share their location? Can they drop a pin? That doesn't have to be something that an individual is a speaking individual, like a vocal, like that communication could happen by using these devices as well. And I think what I said to you is, Claire, I think that's a fantastic strategy and goal. That same kind of thought is like anytime that you can, if somebody's going to have something always with them, that's great to think about. But at the same time, devices get broken, battery charges, lose their charge. So again, I really appreciate this idea of trying to get some descriptors. I remember again, just speaking with Feda and the team about Muhammad, and one of the things that they really wanted was him to be able to be able to like share his phone number, share his phone number. And he was using an augmentative device, or he should be able to. And the thought that we had was, if somebody else handed him or provided him a smartphone, could he punch in the numbers? You don't have to be, again, somebody who can vocalize in order to do that. And your device itself could be broken, but odds are, if you're lost, hopefully somebody who may find you may have a way to communicate. Now, that might not be the way to teach it, but again, asking these questions, as Amy mentioned, and asking them in an open-ended way will help us start to have some of these conversations with families about what might be the most likely. Now, I share that and wanted to connect that to say, I remember from the funding source, they were like, he's never going to be alone, so we don't need to work on that. We're not going to approve that. And it was like, listen, there are things that happen all the time. What if they were in like a motor vehicle accident or something happened, a family member had a stroke or otherwise was debilitated, and that individual is maybe didn't elope, maybe they are wandering and looking for support. All sorts of situations could happen. So just reach out to us if you want any support in how to articulate that or advocate that to make sure that other people see the relevance of it. And Claire, again, I see you adding more information such as having wallets, contact information, being able to write down maybe the house number. These are fantastic ways to really prioritize communication, especially when communication can be such an area of need for the individuals we typically support. And communication in a potentially very dangerous situation can be very critical and life-saving.
Thanks for sharing that, Claire. The next section we have, and the last section that we'll talk about today, is choking and breathing concerns. And I usually start this off with something that happened in our own clinic. A lot of times I think that we don't tackle some of these areas until something unfortunate happens. And in my case, we had a therapist who was working with an elementary school child who did not have pica, so did not typically put items in her mouth and or have any concerns about swallowing non-edible items. But they were blowing up a balloon. And this child really struggled with blowing the balloon. And so instead, when she wasn't able to do it, instead of, asking for help or taking it out, she put the balloon in her mouth and she swallowed it. And it wasn't until then that I learned how dangerous balloons are for children. They are very dangerous if they're swallowed. And so then we had a no balloon policy unless they're like decorative and blown up, as there's something special going on in our clinic as a decorative item. But it's not until sometimes we have an unfortunate incident that we really start thinking about what are the items in our clinic, in homes that we work with, and what potentially could be swallowed and what potentially, if swallowed, can be very dangerous. So recently had a friend who had a 6-year-old child, and they're these like magnetic like builders, and they stick together. And again, this child does not have autism, and was playing with them, took them apart and swallowed it. And thank goodness it was just one of the magnets, but if it would have been two, it would have been, very life-threatening and critical. But these things we need to think about. And so, what items in our spaces and in family spaces could be dangerous, and really working with families to be more educated on that as well. There are a lot of challenges around food and risks around food, and especially if a child has an allergy, how do we teach that child or individual to self-advocate, to identify any foods that may be dangerous to them, and then foods that may be choking risks, especially for young child or people that may have swallowing difficulties. There are other things that have happened with y'all, or thoughts you have around concerns in this area?
So we are recently, this month, actually launching and opening an adult residential campus in South Carolina. I'm very excited to share that. And in the journey of trying to be prepared to set this campus up, we've visited and have toured many other locations around the United States. And we recently visited one in Alabama. And while we were walking through, one of the things we asked was about challenges or concerns or safety things that happened that caught them off guard, or things that maybe they were, that we could be more prepared for and learn from them. And one of the things that they shared was they had, 5, they could count and tell us within a certain period of time, choking situations with the individuals they support. And of those individuals, the majority of them did not have a history of placing things into their mouth. It was like, maybe chewing on something and then they swallowed it accidentally, holding it in their mouth, and then somebody bumped into them. There was all sorts of different scenarios or situations. And what they shared with us was that a particular device that they now have, and they have in every classroom and in different parts of their campus, the life vac. And they said that was actually, it's like a suction that will pull something out. And I recently had the opportunity to speak with like a fire marshal and other people and ask them about the utility of that. And they felt like there was definitely that it was very helpful. And so that, since having met with that location in particular, we decided that we were going to purchase them and have those. I don't work for them. I'm not selling anything. I'm not affiliated with them. But I appreciated hearing from and learning from other individuals. And hopefully that will set us up to be a bit more prepared should something happen. I think people, myself included, tend to not dismiss it, but sort of push it aside if we don't think an individual has the other likelihood to put things in their mouths. But all of us are capable of choking, just like as you mentioned, Amy, from a simple, something like eating food. And there's certainly things like allergies can come up. People can bump into us. Also, all sorts of things can happen. So it's a lot more common, I think, than I realized. And so I'm going to drop a link, but again, nobody's under any obligation. But if they're interested to learn more, I wanted to share that resource.
And Claire, thanks for your comment about, Claire said that she had a girl who had food allergies and they taught her to say that she has food allergies and then hand over a list in her wallet, which is just such a great way to help keep her safe. We've done something similar at schools for students, and where they hand over a card every day to whoever's serving them lunch, but it's a really great way. So back to the ethical code 2.13, selecting, designing, and implementing assessments. And so as we do select, design, and implement assessments, we need to focus on maximizing benefits and minimizing risk of harm to the clients and stakeholders. And that's our goal with using this assessment. And having these conversations during assessments is how can we focus on maximizing those benefits and minimizing risk to a client, and as any of these safety threats are big risks. So some considerations and questions to ask as we think about this is, how do you prepare yourself to have these conversations? Because they are very, very difficult questions. And, especially if I'm asking a parent who's, newer to their journey in autism or has a younger child, it can be really overwhelming and scary. And like I said, a lot of parents, they have a lot of things that are impeding quality of life in the day to day. And so then if we add on something that maybe, less of a likelihood and less of a, impact to their day to day, but still significant, it can be hard to start thinking about that, and scary as a parent as well. Um, we think about what's the benefit of doing this in an interview instead of a questionnaire. And I think we've talked about that it can lead to things that wouldn't have been uncovered, like venomous snakes in a field for that one family. But listen, if I sit down and do this assessment, like there's no way, when you look at this, I mean, it's at least probably 10 pages. There's no way I can ask all the questions on this and like still have a sane person that I'm interviewing and myself still be sane. So, it's up to me as someone asking these questions to scan through and think about what is most pertinent for this child, and what should we be talking about? Because typically I don't have, this as a practitioner, like you don't have 5 hours to just sit down and talk about safety with a family or a caregiver one day. Your time is much more limited. And so sometimes we'll talk about 2 to 3 topics in one sitting. And then, we'll table other topics for the next time that we're able to talk through it. So there's no urgency to do everything at once and to address everything at once. This is a kind of like a journey of safety for an individual, and it's not all going to be tackled in one sitting or one treatment planning. The question of what do we do with this information? Now we have it, and what do we do with it? And we're going to dive a little bit more into it, but hopefully, the idea is to take action and to prioritize, and really work with the family on, okay, these are some areas that are probably pretty critical for your child or loved one, and where should we start? And that's also part of the conversation. And then this last part of how you write goals in a way that's meaningful for the person. And we're going to talk more about that. But, if someone that we come across who hasn't been, working on safety skills, there's a lot of like verbally telling, so this person is going to vocally identify, a stranger or not a stranger. And I recently came across an individual that had been taught by photos to identify strangers and not strangers, and safe people and not safe people. And so, as part of that, they had helping professionals. So, like police officers, firefighters, and this person could really reliably, through these pictures, you'd hold them up and they'd say, that's a police officer, that's a firefighter, good job, yay, way to go. They're people that are safe to talk to. And then, the therapist was walking in the hallway with the client, and they walked by a police officer, and she said, "Oh, who was that? What kind of person was that?" And they had no idea that translated to that was a police officer. And so, we see this a lot of just like, it sounds so great in the moment, like, listen, I don't have police officers, like real legit police officers coming in and out of our clinic or the home program that I'm working with. And so, like, you have to work with what you've got. But this ability to translate and generalize from like a flashcard that this is a police officer, or one of those puzzles that has police officers, like it doesn't always translate to this is a real live police officer and this is who I go to if I need help. And so that really comes together in how we think about meaningful goals, which we're going to talk about in a minute, but good things to think about. Okay, we wanted to just dive into some different safety skills that might be taught using something like a smartphone. Amanda touched on these a little bit, like being able to drop a pin or pull up identifying information. But any other like ideas or things that y'all have done with teaching safety skills through a smartphone before I pull up some different ideas that we have to share? Okay, wow. One of them, as we talked about, was dropping a pin. We can also track devices now, and that may not be as important to teach the client, but I mean, I would say 9 out of 10 caregivers that I work with don't know how to do this. And so it's just as important to teach the caregiver how to support this, and that, having a device for them can be really helpful. Accepting and making FaceTime calls. And so you know, if I'm lost and I don't know where I am and I'm not necessarily able to flag down a helper or communicate it, just being able to make a FaceTime call and show my area, it can be helpful. That then, if I'm calling Amanda on FaceTime, she can say, okay, I know where you are. You're at the corner of Preston and Forest, and I'll be right there. And so it can be really helpful if you're able to, accept a FaceTime and know to make it if you're in trouble. Teaching phone numbers and recognizing the number. Yeah, being able to input, as Amanda said, like if you just get handed someone else's device and it's not programmed in, like, can you type in a phone number and then that person can call them? Using your phone as a communication device. And if you have another type of AAC that there's, some way to use your phone, that there's an app on here that can be used alternatively if your other device has their battery down. Also being able to type things into notes or have things saved into notes to be able to pull up your notes section. So if I'm lost and someone asks me like, what's my name, that I can just show them the notes section and it'll pull right up. And that goes right along with storing emergency information here. It's such a great way to have your emergency information. And if it's someone that, they're able to reliably like always have their phone with them, then this could be a great way to have identifying information on them. texting and making phone calls, as we've talked about, arranging transportation. So everything from like getting a lift to looking at the bus stops and being able to navigate the bus stops. Um, I recently had a parent who picked their kid up from school every day. They were in a community college program, and one day their child just said like, "Hey mom, I got myself home. Like I looked up all the bus stops and I figured it out." And so the phone can be such a useful tool for someone, to get around and to figure things out like transportation, whether Uber or buses. Any other things that come to mind for phones?
One quick thing I'll share, and I see that Marcia has commented here in the chat as well about teaching phone numbers being really helpful. Recognizing the number two can as well can also be helpful. Yes, I agree with that. One thing that I've done, and it all depends on like the length of passwords and passcodes now, but if you think about getting into a smart device, it often has the ability to set a lock, like a passcode, right, for a lock to unlock it. Well, I've worked with families where we put a portion of their phone number or all of their phone number, right, as the code. Their child learns so quickly what that code is to get into that smartphone that we can then transfer that over and be like, that was your phone number. So there's ways in which we can also use the skills of behavior analysis to capture the motivation and then hopefully teach a skill and provide reinforcement for that skill. Yes. Yes. Thank you. I wanted to make that connection, and thank you for.
Okay, some other examples of safety skills that can be taught. So, identifying safe places during different types of emergencies. So, where do I go if there is a tornado, if there is a lockdown drill, and being able to get myself there to stay calm and get out of my routine in those situations. We taught a child how to safely exit and get to an exit door when the fire alarm went off. And we were with him like 6 months later, and the tornado alarm went off, and he ran to the exit door. And he was the only kid in a room full of children that even responded to the alarm going off. But obviously, it wasn't the right response. That in a tornado drill, like you're actually not like wanting to run to the exit door. And so, really being able to identify, different alarms, different places, different situations, and where do we go for each. How we use our communication tools to seek help. And I know Amanda recently worked with an individual, and they put like on the main screen of their AAC, like this is my name, and other pertinent safety skills. And we really try to do that when we're working with kids with AAC or adults, of how do we make that programmed into the AAC device and very easy to find. Yeah, again, responding to different emergencies. Go ahead.
Sorry, I was just going to add in and say, something that came up with that too was when we're working, especially if we're looking at using AAC devices and you have someone tell you their birthday, like my birthday is June 10th, that's helpful, but it's more helpful if it's their date of birth, because then we actually know how old somebody is. So that again was something that came up for me only while working with an individual and going, oh, I don't know if she's 10, 12, 14, I'm not sure. But once we shifted it and taught her how to say it with the date of birth, it would be much more clear, especially for a medical professional.
Yeah, thanks for sharing that. A couple other things is how to follow emergency instructions, and how do we recognize like the different tones of voice and when it's really critical that we're following through from a caregiver, and then identifying different safety hazards. And I think that's one that a lot of people do. Just growing up, it was very much, there's a lot of education on things in the home that could be dangerous, like cleaning products. But how do we recognize these different things and potential warning signs that we should stay away from? We wanted to touch on first aid skills, and there's a whole gamut. I'm not gonna read through these, but it's not just enough to teach like if we're looking at using the stove safely and the microwave safely, what happens when, so many times I'm a terrible cook, but like I take something out of the oven and I burn myself, or even on the microwave and it's like really, really hot. And so what do we do? And those are things that we have to think through. Like, okay, we're teaching someone to use the microwave, but what happens when something gets too hot and they grab it out of the microwave and they need to like they burn their finger and they need to run it under cold water. And Amanda had a great situation or unfortunate situation that happened. You want to bring that one up too?
Oh goodness. Yeah, it was just about a year ago, recently, where I had my fire alarms were going off, in my home, and fortunately, I had a friend and her daughter staying the night, and the daughter's 13 and we're awake, but we didn't want her mom to wake up, so we're like, we'll go change all the batteries in the fire alarms, as quickly and as quietly as we can. I was on the ladder. We were done with the third one. I literally said, well, that was easy because we got it to go in, third time's a charm. And on the last rung on the ladder, I slipped and caught my toe. And I was not wearing shoes. So PSA, wear shoes when on a ladder. I don't wear shoes in my home, so it didn't occur to me to put them on before getting on the ladder. It will always occur to me now, because I essentially severed my toe and immediately had to know what to do. And it was like, again, in that high crisis moment, I don't even know how I knew what to do. It was very instinctual. Immediately grab a towel, wrap it around, apply pressure, try to elevate it. Do I need ice? Was able to ask that individual, hey, can you go make sure it's still, sorry, it was a little bit gross. It was fortunately still attached, fully. So there was nothing to go and retrieve. But get my phone, wake up your mom. Okay. And here's how we're going to go. And I was so grateful that I had that preparation for that emergency, that I would know what to do. And half of it I think I got from probably watching television or like osmosis from all the years of CPR or first aid. Finally had to put it into action. But in that moment, those steps saved my toe. Like in those moments, those steps minimized the impact of the injury. And so if we can work with teaching the individuals we support how to apply pressure, how to, put something under running water, when to go and get a Band-Aid, when it's more intense than a Band-Aid, those things could actually be very critical, and time crucial, and in minimizing damage or injury, not just for the individual that we're supporting, but to anybody that they might be around. Imagine that their caregiver, their parent falls, bangs their head, they'll be able to know to put something under their head or to stabilize them or to not move them. That again could be critical and could be life-saving. Yeah, thanks for letting me share, Amy.
Oh, thanks for sharing that. So we're going to get into a little bit more of how you do this. And this is where kind of my research expertise is in something called behavior skills training. And it's something that, as BCBAs we use and we know it's effective, but just for reviewing it, it entails 6 basic steps. So the first is instruction, and we want to give a really clear and concise explanation of the skill or behavior that we're wanting to work on. The second part is modeling. So how do we demonstrate the skill or behavior to that learner? So I'm going to model the skill, and then we're going to practice it over and over and over again. And the learner is going to practice it. And an aspect to that practicing is giving feedback. So we want to give constructive feedback when something's done incorrectly, and then a lot of reinforcement, just like we do in our professions, to the learner as they're practicing. And we repeat over and over again until they've truly acquired the skill. And the last step is generalization. And this is a critical aspect, which is repeating it in all different types of ways. So, if I teach a child that when the fire alarm goes off and I'm with them and they're in their playroom, that they can get safely to their exit door, it's not enough. That we need to work on it throughout the house with different sounding fire alarms, without me there, with different people in the home, with a party going on, all sorts of different scenarios to reliably know that they, mastered the skill and it's generalized to other circumstances. And so the beauty of behavior skills training, or BST, is that there have been studies done that show that it really works when it comes to safety skills, everything in, what do we do if a child encounters a gun, to abduction prevention, to using a fire extinguisher or safely exiting the house. Ray Miltenberger has done a lot of research in this area, and one study that he was involved with is really interesting. And they had kids who were typically developing without autism, and they were taught that if they see a gun, a firearm, that they should not touch it and they should immediately tell an adult or caregiver. And so they set up a scenario with like pretend, bedroom situation, whether wherever it was, and they sent kids in there with a camera, and kids that were taught to not touch the gun and to tell an adult still ended up picking up the gun, and then sometimes they would go tell the adult after. But again, this is so critical that if we teach outside of these scenarios, just listen, I'm telling my kiddo, if you see a gun, this is what you do. It doesn't necessarily, the research says that it doesn't translate to practice. And that's why BST is so important, because the research with BST shows that when we use BST procedures, that it actually does translate to success and is effective in teaching the safety skills versus that say do. So again, if I'm just teaching someone, vocally, what do you do when you cross the street? Well, I look both ways. It doesn't mean that when they get to the street that they're going to still look both ways and safely cross the street. A BST is composed of a lot of different evidence-based principles. So everything from prompting, differential reinforcement, discrete trial teaching, task analysis, modeling. I mean, these are components of BST. And so BST has robust research around its components. So when teaching fire evacuations, we listed some skills here that can be taught using BST, everything from recognizing an alarm to staying low in the event of seeing fire, using exits and finding exits, calling for help, and meeting at a safe spot. We wrote in here it's okay to teach to break screens in an emergency because, depending on the individual, it may be safer to teach them how to break a window on the second floor than to do something else. Amanda has a great example here that I would love for her to chat about.
Yes. So I was actually speaking with a friend of mine and her son. And one of the things that we were talking about was that, he's very much a rule follower, and rightfully so. And we really appreciate that about Brad. But she said, when she thought about him, when she spoke to him, and he's in his 30s, and said, what would you do in the fire if you need to go out the window? And his response was, we don't break the window. Like, we don't push the windows. That would be bad for the house. And so it got us all thinking, to that point, like, you may need to teach these rules. You may need to say out loud, like, if it's on fire, if there's smoke, we can break the window, like we can push the screen out. Under that condition, it's okay. We also had situations where everybody felt so impacted after they experienced too and learned about Theta and Mu, that individual would say, my child isn't on the spectrum, or my child is higher functioning or more language abled, and they would go and ask their child, hey, what would you do? And they said, I'd wait for you to come get me. So just asking, what would you do in the event, yielded so much information that we were not necessarily anticipating. And so asking these questions really can be incredibly informative and life-saving. And then just something quickly I'll mention is the color of exit signs are often red. If you think about a fire exit, it says exit, exit. Sometimes you'll see green ones that say exit. Other times you'll see green ones that are actually no words, but an image like the one on the screen. There's some research behind that talks about red. What does red mean? Universally, it can mean danger, stop, don't, harm, bad. And what we want someone to do is feel safe. We want them to know to come this way, and green means go. And so even in the adult campus that we are working with, and building and developing, even that level of detail was very important to me. So working with the powers that be and the fire marshals and the contractors, asking them, how hard is it to make it from a red to a green sign? They said it's actually just a switch on the inside of the signs that we have and a different little placard. You slip in a green instead of a red. So I'm seeing it become more of an option and less of something that would take some effort. So something to think about, something to kind of take into account. As I'm currently in San Francisco, and as I've been in San Francisco over the last few days, Amy, you'll see this, I'll send them to you later. I've been taking photos of all the different exit signs, what colors they are, if they're images, if they're words, and what type of building I'm in, because I'm interested to see if there's just a trend I can notice as a consumer of that environment. So yeah, I think it's really important. And the last thing I'll say about that is I also noticed at Walt Disney World that the exit signs are on the ground and as well as up on the air and I up higher on the wall. And I asked about it and they said, well, we have a lot of children, but also smoke rises and it's harder to see. And you can actually see the signs better when they're on the ground, especially if you're crawling. So a lot of times you'll see places that will have a pathway illuminated, even if they don't have their exit signs lower. Things to think about and things I didn't know that I needed to know, but I'm so grateful that I've learned.
Thanks for sharing that. Right now, we wanted to walk you through an example. So, how we use BST to teach safety skills. And this is what I did for my dissertation study, but we taught a prerequisite fire exiting procedure. And so, for kids under age 8, the recommendation is not that we meet at an area outside the home like a mailbox, which is what I learned when I was a kid. But instead, it's to get to a safe exiting door. And the reason, especially with the population that we work with, that I wouldn't want to teach how, meeting at a mailbox is that there's a lot of skills associated with being on the street and at a mailbox. And that could be equally as dangerous. So if we're in the street, we could, and we don't have skills for, safe behavior on the street, it could be quite dangerous. Another thing is, again, I mentioned I'm a terrible cook. And so what happens if my smoke alarm goes off in my home and it's not a true fire and I'm trying to deal with that and my kiddo is halfway across the street and is exited my house, then I have another safety problem. I also, a lot of times we don't want to teach such young children how to open the doors and get out. So that is another safety concern. So what we did was we taught how to get safely to an exit door. And these were the 4 things that we looked at. So one was initiating this procedure within 15 seconds of hearing the fire alarm. So we didn't want too much of a delay. Really this idea that we hear a fire alarm and we need to stop what we're doing and take action. And after we do that, we're walking or running to within 1 foot of an exit door. And then we want to wait at the exit door. For the study, we did 10 seconds, but ideally we really want to wait until an adult comes. And then the whole procedure should be done within 2 minutes or less of the initial fire alarm sounding. Also an ability, like if we're upstairs and a kid's exiting the building, we don't want them to stop at the TV that's playing downstairs or at their favorite toy or go to a different room and then come out. They need to exit quickly. So these are the steps that we looked at. Part of the BST procedure is instructions. And for each child, we individualize the way that we taught them how to exit. You'll see on the right hand of your screen, there are directions written very simply paired with visuals. And this is what we went over with each child. And it was changed somewhat and individualized for each child. But this is kind of one example that we used of, the fire alarm goes off. I need to stop what I'm doing. I go to the door. I do it fast. And I wait at the door for a parent or adult. And what you see on the left is the words that we used as we were exiting and or some sort of version of this. And I wanted to show you the videos from kind of before and during and after of what it looked like. We had 4 children in this particular study, and they all came from middle to upper class families, very educated parents. And it was really interesting to me that each child that we worked with, the fire alarm went off. They also were frequently in preschool programs. And when the fire alarm went off, each child did not demonstrate kind of any sort of understanding that this was something, dangerous, that they needed to stop what they were doing, that they needed to leave, that there was anything critical happening. And the 4 kids, they either sat where they were and didn't really move much, or they tended to kind of run around the room playing. And so those were the 2 main responses that we had. During our baseline, when we were just seeing what the responses were, the therapist could say, I hear a fire alarm, but that was it. I want to go ahead and play this for you.
I heard a fire alarm. So I know you're here. You stopped the fire. Not right now.
Amanda said she had a hard time hearing the fire alarm. I'm sorry if that was hard for you to hear. There was a loud fire alarm and it was played through a phone to a speaker, and so meant to emulate what a real fire alarm would sound like, and not as piercing. Like, I'm in an office building and it's really, really loud and piercing if it goes off here, so probably not to that extreme. But that was what was happening in this child, as you could see. Just he stayed there and asked for it to be turned off, but that's about it. And this is what we saw again, kind of similar across the board. This was like super easy. So I just recorded different fire alarms from YouTube on my phone, and that's what we used in this. And it did not take much to do that, and I didn't need anything fancy. I didn't have to pay for anything, and so it was a very simple procedure that was able to be replicated. Something that we did think about was the type of fire alarm we used, and it would be really ideal to have the same fire alarm for that person's house. So if you're able to do a trial and record that fire alarm, like, that is beautiful, because if it goes off, like, they've learned that sound. And you can also work on other sounds, but unfortunately, a lot of the fire alarms that we had were in difficult to reach places, or they also had, as when they went off for the test, it would say, this is a test, this is a test. And so then it wasn't really what they would end up hearing in the event of a true fire. This is what instruction and modeling look like. This was during COVID, and so you'll see masks on our BCBAs and therapists.
Stop. Go to the front door. Do it fast. And wait at the door for a parent or an adult. So first it will be my turn. I'm gonna show you what to do when you hear a fire alarm. I hear a fire alarm. Oh, I need to stop. I go to the front door and I do it quick. And I wait at the door for a parent or an adult. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's waiting.
Here she really beautifully showed him the procedure. She was articulating the steps that they were doing it, and she provided reinforcement during that. This is what role play and feedback look like.
All right, your turn. You're a fire alarm. I need to stop. I go to the front door. And I do it really fast. Good, Maddie. That was nice stopping and going straight to the front door. Also going so fast.
And the last video was what it looks like when he does it by himself.
All right.
So this was done, as part of a study. And I mean, as I watch this, like there are problems to this, right? So in his 100% responding, the therapist or BCBA is following him as he exit. They're in the room when the fire alarm goes off. And so this is not the last step of this. For the study, it was. But if you're talking about real life, I'm working on this for, clients that I work with in the home. I mean, the next steps are that the therapist isn't in the room, that they don't see a therapist or a parent as they're going down the stairs and get to the door. And so there's a lot of next steps, and continuing thinking about what would this look like in the event that it was a real fire, or a real fire alarm going off, and not practice like this. Some other factors to consider. Did y'all hear that? I know Amanda had trouble hearing it. Madison, were you able to hear it?
I could only hear it when she was talking.
I'm sorry, everyone. Well, that's the important thing. I mean, you could see that he was exiting in that one. So I'm glad you got to at least watch that. But some factors to consider, another aspect that we haven't talked about is maintenance. And so we could, practice this and get generalization and have 100%, but is it maintaining? And so we really want to make sure that down the road that, especially if we're looking at like this kiddo, that we're practicing it, that we're checking in months down the line that he still is able to do this. What prerequisite skills do we need to prioritize? So is it the ability to respond, stop what we're doing and go when there are loud noises, that we can even just follow a simple direction, being able to follow a model. There's a lot of prerequisite skills that we need to be successful in this procedure. And so thinking through those. Again, using really realistic alarms and practice scenarios. We're doing this in the house, but what happens when you're in other community areas? Are you still able to respond successfully to fire alarms, or in your school? So there's a lot of different places and scenarios. As far as like props and people and materials that are there. I think one of the best things about this particular procedure is that you don't need a lot. It's not specific to people. It's not specific to certain materials. It's very low cost. This took at a max 5 to 10 minutes per day that we worked on it. So not a lot of investment on our part, but a pretty high return for learning the skill to be able to stop what you're doing and identify that that's a fire alarm and you need to get to an exit door. And then the next question is really, what are the next steps that we need to teach for that person? Once we master the ability to do this, then depending on the age it may be, being able to exit to the street and meet at that safe spot. It may be as far as fire extinguishers. It may be, what do we do when there's a fire in my room and I need to get low into the ground and check if the doors are hot, or go to the window if going to the door is not a possibility. There's a lot of further steps, and we never stop at that point. The next thing we wanted to just kind of quickly go over is writing goals, because if we're gonna start to think about this, then especially for our behavior analysts that are part of this, we need to have the goals in our treatment plans, and that starts with having these critical discussions that we've talked about through this, and just including them, and then thinking again about prioritizing them and where do we start, and it may be starting with 1 or 2. We don't have to start with 10 or 20, even though there may be 10 or 20 that we can identify. And then thinking together how we can facilitate BST and teaching opportunities that mimic, as close to real life situations as possible. And it can sometimes take a lot of creative thinking to make that happen. And so in my team, we collaborate a lot of, okay, this is a critical safety skill. For example, the kid who was really interested in going into cars, but like, how can we target it using BST and as real life example without like having strangers' cars open and walking in a parking lot and working on that. So it's a kid can take a lot of creativity and collaboration to get there. But starting somewhere is kind of the bottom line, is that we have to start somewhere. Which brings us back to 2.16 in the ethical code. So describing behavior change interventions before implementations and how we plan them and how we talk about them. And that we need to also explain the environmental conditions necessary for effective implementation of the intervention to our stakeholders and clients. A lot of times I have, rightfully so, a parent who's very concerned about if we're going to teach safe crossing of streets, like how are we going to do that to ensure that their child or loved one is safe? And so these are conversations to have together to make sure that when we are teaching them in these real life scenarios, that we're keeping clients safe and that everyone feels comfortable and good with our plan moving forward.
Amy, on this part here, I would like to also add, circling back to the point that you made earlier about why we recommend this be more of an interview than a questionnaire as well. Sometimes just that conversation and that thought-provoking piece can yield more information. And I'm thinking about it as it connects here to describing, well, one, the questions, the assessment process, but also the interventions. So there was a family that I had the opportunity to go through portions of the assessment with in the last couple of months. And I asked the question about, did they have any concerns with like safety in the kitchen or safety around sharp objects? And they were like, nope, we're good. Or if they had just filled it out, I think they would have said, no, we're good, right? If it was a yes or no question as well. But I said to them, tell me about sharp objects like knives. And they said, oh gosh, one time, and this was for a 4-year-old, he had climbed on a counter, had the knife. He wasn't particularly aware of how sharp or dangerous it was, but was holding it, in an unsafe way and wandering and walking around the home when they realized it, took the knife. And I said, well, where are your knives now? Like, how did you solve this problem? This is amazing. You don't have this problem. Like, fantastic, great job. What'd you do? And they said, well, we just put our knives in the microwave now, like the whole block of knives. And they were thinking like, it's up, it's elevated, it has a door. The door is harder for the child to open. We're safe. But then I kind of just asked to implore them, like, well, have you thought about what if somebody started the microwave with like metal in your microwave? Like now we have potentially another safety issue. And I bring that example up right now because it's very important for us as clinicians to realize and recognize, whether we have children or family of our own, that like there's a lot going on in these families' homes and in their lives. We do need to work with them to prioritize it. We also need to make sure that not just the way we describe it, but the way we design the interventions and our questions are sensitive to the fact that they don't have necessarily a team of people in the home. They may not have a background in data collection, and they also may have habituated in many ways or accommodated their life in ways that we can let them know, hey, maybe we can open your world back up. Maybe there's a way to put your knife somewhere else in the home that doesn't present an additional safety concern while also meeting the needs that you have to keep your child safe. So just wanted to kind of reiterate that whole point. Like you said, it takes a lot of creativity and collaboration. It is definitely not something where we would be telling people what to do or even telling them which things they should focus on, but having that conversation and the communication so that we are creating that awareness. But like you said, tackling and starting somewhere. It can be very overwhelming. But yes, there you go, right there again, involving the clients and the stakeholders. But to your point that you made earlier as well, start somewhere and go from there. Yes. Thanks, Amy.
Thank you.
You want me to take
Sure, I'll start off and then Amanda, you can take over. Water safety, we have just a few goals here. And again, these are thinking about things also that are teachable. So, identifying potential water hazards is a first step. Like where, there's a body of water and it's dangerous and I should only be there with, a caregiver or safe adult with me. And then demonstrating safe behaviors near water bodies. This is something that we're able to work with without actually getting it in the water. So we have a lot of families that have pools and we work on, electronics stay away from the water, that there's a safe place that they go if we're outside, and that our iPad, our communication device, our cell phone, it doesn't go in the water. And then, things like other rules that we use when we're around water bodies, that we're not running around the edges, we're not putting our body parts in it unless we're like meant to go swimming and with those safe people. And then, what are the goals within water? And those aren't always ones that we can tackle, myself as a BCBA, but we can work with the family on prioritizing this in their time or their swim lessons, whatever it may be. One thing we have on here is wearing a life jacket, and that is something that I can do with someone who may be struggling with keeping up or tolerating a life jacket on, that we can have one here and we can work on tolerating that and feeling really good and safe and comfortable for the family that's going to be on the water this summer and needing them to wear a life jacket.
You beautifully articulated that. And here we have a couple of additional, safety goals. And I love that we have that one there. Safely uses or stays away from knives. I knew that one was important, definitely important to me. Also, like as you mentioned a couple of times, the ability to discriminate, making those conditional discriminations is another area in which we are trained as behavior analysts, as teachers, as psychologists. We might have different language around that, but knowing that I can use this knife to spread, jelly on my bread. Great. This knife is for cutting something sharp. I need an adult for this, or I need different protections in place. Yes, keeping fingers, hands, objects away from the garbage disposal. Knowing that what that means when the switch is off or on in the on condition. Not turning it on when someone else is using the sink. There's so many different aspects of safety that are necessary for us to all learn, but also knowing when, under what conditions. Like I can turn on the garbage disposal when there's just, food remnants there, or I can only do it if I'm with a parent, or only a parent can do it, or whatever that might look like. I think that allows these to also, I think you've done a beautiful job at, we've picked some examples that allow people to see it. This can be so individualized. It could be for an early learner, it could be for someone who has a very complex understanding of language, but just making sure that we don't wait until there's an injury or an accident to start programming for these as programs.
As far as like being really individualized, I'm just going to add on that, doing the walk around with a family, if you're doing in-home services, can be really eye-opening. And a lot of times we'll catch things that we wouldn't catch otherwise in terms of environmental safety. So, in my own home this weekend, my husband had driven his motorcycle and just around the block, but I didn't even know this until it happened in our house, but that when a motorcycle is very hot, if a child touches it, like it can cause severe burns. And so my toddler, touched the motorcycle, tried to climb on it, and had excruciatingly bad burns from it. But that's something like not every house has a motorcycle. And that's, one thing, but even, I talk about safety, and my husband and I joked, he's like, "What are you doing today?" I'm like, "Giving a lecture on safety." We just had a big accident in our house. But these things are so individualized per home. And I have a creek in my yard. And so for us, that is a big safety hazard for our child, and one that we have done a lot of safety planning around. But it's very individualized for each home and each family and each individual, each client that we're working with. So kind of just to sum it all up, we've created this assessment of open-ended questions that starts the conversation, and we really hope you use it. I've already seen in my email that some of y'all have gone in and requested it, and I'm real excited about that. But please, if you haven't already, go on to either of our websites, and we'll share that assessment with you. We're coming up with a more concrete document that has some of these goals that we just talked about to get people started, and also how they tie into the diagnostic criteria. Because again, Amanda's mentioned that insurance plans, that a lot of times if we're working with insurance, we also have to be able to get that goal approved and the treatment plan approved. And so we think a lot about how it ties to diagnostic criteria of autism in doing so. And we invite you to join us in the conversation, in this ongoing conversation, and reach out to us to help us, as we keep moving forward with this project and sharing this information with others. And we're really grateful that you joined us today, and appreciative. And, what we're doing is really a call to action, to ask these questions and to use it to inform our treatment planning and the goals for each client. And here's our contact information, our emails. But again, please reach out to us. Are there any other kind of comments or questions as we close it up?
I think
We
you
certainly Oh, sorry, Madison. I was just going to say we certainly appreciate the comments that were in the chat as well. And we know that sometimes people have thoughts or questions afterwards. So just to reiterate what Amy said, please do. We are one between the two of us, one of us will get back to you. Amy's usually the better one at that, but certainly do reach out to both of us because what we have found is a lot of the information that we've learned throughout the process comes from the conversations. For example, we had a participant at our talk last year in Pennsylvania who is autistic and also volunteering with the fire department and was able to let us know about the different types of fire extinguishers, or that you want them between like your door and your exits or near your exit, so that you can be kind of doing this as you're trying to get out of the home. Things that we've learned, I guess at some point, Amy, we should probably consider even putting together a quick booklet on just like safety tips and things. Those might be good things that we could provide as resources, even to families as handouts. But more importantly, it's keeping these conversations going and not having what we would experience, sometimes drift, or it just doesn't seem as pertinent in what's going on in front of us right in the moment today. But I assure you, Amy and I are constantly looking at the news, and we see opportunity or through a lot of tragedies for reminders of like, okay, here's another situation, here's another circumstance, here's another opportunity for us to learn what we can do in the future to prepare and prevent and avoid as much as possible. Not all tragedies and dangers and injuries can be prevented, but they certainly won't be if we're not continuing the conversation. So thanks, Madison, for letting me share that as well as we were concluding today.
No, I think that's fantastic. Thank you both for sharing your personal experiences and providing some guidance for where and how to start. I love the idea of doing a walk around with the family to help individualize those goals. So I think that's fantastic. And Amy, I'm so sorry to hear about your daughter, but I hope that she's doing better.
Thanks. Well, we share these stories because, we didn't know, as Amanda said, like, we didn't know a lot of this stuff before. And so sometimes we feel like the more stories we can tell, like, the more we can prevent something happening down the road. So hopefully other kids that, we can prevent that down the road. But thanks.
Yeah, absolutely. It can happen to anybody, and I think it's
Yeah,
important
thank
to
you.
prepare for. But thank you everybody else for joining us. As I mentioned previously, I will be sharing a link for the post-webinar survey and quiz after reviewing the attendance records. But this does conclude today's workshop. So thank you for joining us. And again, thank you so much, Amy and Amanda, for presenting on a very, very, very needed topic.
Thank you for having us. Bye.
Bye.